Okay, Bismillah ar-Rahman ar-Rahim. We'll start our first session for today. My name is Dr. Kadhim Suleiman from Oman, and my co-chairperson, Dr. Mary Welch, President of American College of Cardiology. She will be the first speaker, so it's a great pleasure for me to introduce Dr. Mary Welch. As I said, she's the current president of the American College of Cardiology. She's the medical director of heart failure and cardiac transplant program and the director of nuclear cardiology at St. Vincent's Heart Center. So she's going to talk to us today about cardiovascular disease in women.
Thank you very much for that kind introduction, and welcome to everyone to this combined American College of Cardiology Gulf Heart Association joint session. I'm going to talk today about cardiovascular disease in women. Most of what I'm going to talk about involves data that we have from the United States, but I do have some data for this region of the world as well. And but there is data that is lacking in this region of the world, so I'm going to, for the most part, be talking about U.S. data. So what I want to speak about today with regard to cardiovascular disease in women is, are there sex-specific differences in several different areas? So we're going to talk about the prevalence and incidence of cardiovascular disease in women, and then some of the risk factors: hypertension, smoking, and obesity. And then a little bit about the differences between women and men with regard to atrial fibrillation, heart failure, and lastly, focus on how much information we have about women and cardiovascular disease. United States life expectancy is shown on this slide from 1900 to 2011. And what you can see is that the pink graph, the pink line is women, the blue is men. Over time, from 1900 onward, we've seen an increase in life expectancy for women and men. And what we see is that women have lived longer than men for many years, and this has been termed the women's advantage. This is life expectancy in Qatar, and similarly, women outlive men and have for many years. So you can see that in this region of the world as well, there's a woman's advantage. Women die later in life, often of the same causes, but the onset of disease, in particular cardiovascular disease, comes later in life. And this is one of the reasons for the women's advantage with regard to life expectancy. Here's what we know about the prevalence of cardiovascular disease in adults in the United States. The NHANES data is compiled every year, and we can compare through the years the prevalence of diseases in the United States. In this particular case, cardiovascular disease includes coronary heart disease, heart failure, stroke, and hypertension. And what we see is that these diseases for both women and men come with higher prevalence later in life, so that by the 8th decade, these are very prevalent diseases for both women and men. This is coronary heart disease alone, looking again at the NHANES data in the survey from 2009 to 2012. So for coronary heart disease, there's a very distinct difference in prevalence between women and men, with the prevalence being much higher in men in every decade of life, including the later decades. But in the red bars, which is the data on women, we see that there's a growing prevalence through the aging, as the population ages, so that the highest prevalence in women is in the 8th decade and beyond. This shows us data on myocardial infarction in the same survey, the NHANES survey. And again, although the disease is much more prevalent in men in every decade of life, for women, we see a growing prevalence towards older age. This shows us the incidence, not the prevalence, the incidence of cardiovascular disease, heart failure, stroke, or intermittent claudication in the Framingham Heart Study. And again, the incidence is much higher for men and women, ages 65 to 74, and then even greater. By the time men and women are in their 8th decade, the incidence is very high in the United States of all of these diseases. There's quite a difference, quite a variation in CHD, cardiac coronary heart disease death rate in the United States. This is a compelling map of the United States showing the risk of death of women from cardiovascular disease in the U.S. The death rate is very concentrated in the South and in the Deep South, those states of Alabama and Georgia. There's a lot that plays into this difference in CHD death rates. Some of them, the issues involve socioeconomic data, lifestyle, but also access to medical care as well. So important to remember, and this is true in other countries of the world, there's a wide geographic and socioeconomic difference in death rates for women from cardiovascular disease. And these are some of the issues that are being addressed in the United States with regard to increasing access to health care for women, especially in these Deep South states. So the good news is that deaths attributed to cardiovascular disease have gone down in the United States pretty dramatically over the last several decades. This curve shows deaths for both women and men in the United States, again from 1900 to more recently in 2010. So we've seen this decline, and this is overall data from both women and men. And these are the same data, but divided into women and men, and you can see the steep decline in cardiovascular disease mortality trends for both women and men through the years, with the steeper decline actually coming in death rates for women. However, hospital discharges for cardiovascular disease is very common for both women and men, reaching its peak in the around 2000, but again, declining. A lot of what we see with regard to hospitalization rates in the United States now for this disease involves heart failure hospitalizations, which are one of the most prevalent diagnoses for hospitalization in the United States. When we think of major causes of death for women, it's important to think about how old women are at the time of death. So if we look at all ages, on the far left of this graph, blue is cardiovascular disease, and purple is cancer. So if we take all ages, women are slightly more likely to die of cardiovascular disease. But cancer is a diagnosis that results in women's mortality early on. In the middle bars, we see that for women who are under the age of 85, they commonly die of cancer. However, over the age of 85, see how that purple bar decreases? And we see that the predominant mode of death is from cardiovascular disease. So if we put this all together, more women in the United States die of cardiovascular disease than any other disease, but younger women are dying of cancer. Let's talk a little bit about hypertension. Hypertension is a driving risk factor for women with regard to the development of cardiovascular disease. So I want to call your attention to this risk factor so that we make sure that we address this risk factor for our women and our male patients. The prevalence of hypertension in the United States grows with each decade. This is the most recent data, again from NHANES, and you can see that by the 7th decade, almost 80% of women have hypertension in the United States. I'm going to show you in a few slides that hypertension is a driving risk factor for the development of heart failure, and so this is important to recognize in both our men and women patients. The United States ACC-AHA guidelines just came out in November with updated guidelines for the treatment of hypertension, and we've dropped that hypertension goal to 130/80, which is a new goal for both women and men. And an important piece of these new guidelines is that we recommend lifestyle changes as an adjunct to medical therapy for all patients. So again, by the time women in the United States are in their 7th and then 8th decade, it is very common to have hypertension. There are major differences in the prevalence of hypertension depending on the ethnicity of women and men. I want to call your attention to the fact that in the middle bars, these are African American men and women, significantly higher prevalence of hypertension at all times analyzed in the earlier time frame, 1988 to 94, and up till the more current time, 2007 to 2012. So this is a very prevalent disease in our African American patients. Although prevalent in all ethnicities, this is a special group of patients who are especially vulnerable. The age-adjusted mortality rates, this is a little bit harder to see, but important to remember that the NHANES survey has been able to look at mortality due to hypertension, and I show this just to remind us that the mortality with regard to hypertension as a risk factor is much higher for African American men and women than it is for other ethnicities. What about smoking as a risk factor for developing cardiovascular disease? This is a map of the world showing the smoking prevalence in the world, and of note for both the U.S. and here in Qatar and other areas of the region, smoking prevalence is about the same in the United States as it is here. This is all comers, this is men and women. Look at the smoking rate in Greenland. It's amazing. So smoking, you can see, is concentrated in different parts of the world. There are some parts of the world where we have very little data because smoking is underreported. So this is a major risk factor for us to address. This shows us smoking rate in the United States in 2015. This is the most recent data that's available. And so you can see there's a decline over time in smoking rate for men and women. The lines are showing us that women at any point in time are less commonly smokers than men. And the bar on the right shows us that at any given age, fewer women than men smoke. So we see a gradual decline in the U.S. and fewer women are smoking. Here's the same information for this country, 2015. Look at how few women smoke. Those are women who report smoking. It's true in the Middle East and other parts of Asia that the underreporting of smoking by women is very common. This is because women aren't as public about smoking, and there are various forms of tobacco consumption that are underreported, such as other forms of tobacco products. It is likely that women smoke much less frequently in the region. However, it is underreported. So it's still a very important question to ask our patients to identify our women smokers and to help them quit. So the prevalence of smoking for adults in the United States by race and ethnicity is extremely different, and I show you the differences here so that similarly to the data that I showed you on hypertension, it's important to recognize the ethnicity of the person and identify the risk of smoking. Let's talk a little bit about obesity as a risk factor for the development of cardiovascular disease and what we know about the rates of obesity in men versus women. Obesity is prevalent globally, and it's becoming a problem around the world. The leading areas of obesity in the world you can see are in the orange, and those include the United States, and you can see that the Middle East is included here as well. So this is something for all of us to pay attention to. At this time in the United States, this data is the most recent from 2015. Almost 40% of the United States population is now obese. This is largely driven by a more Western lifestyle, which includes a very sedentary lifestyle. but also an increase in sugar consumption. These are things that over the last many decades have driven the obesity epidemic, and we know that obesity is an independent risk factor for the development of cardiovascular disease. This is the age-adjusted prevalence of obesity in adults in the United States for men and for women. And I think that the importance of this graph shows us that women are slightly more likely to, with regard to prevalence, the prevalence of obesity is higher in women at all time points measured. And this is the Framingham heart study, risk of developing heart disease for a man or a woman aged 50 to 54 years of age, according to the levels of various risk factors. And I include this just to remind us that these risk factors are cumulative in our patients' risk of developing cardiovascular disease, and we can use these type of risk calculators to look at a given patient and determine what his or her risk is for going on and developing cardiovascular disease. What are the differences between women and men with regard to atrial fibrillation? This is the prevalence rate over the world of atrial fibrillation. It is largely a disease that we see in the United States and Canada. It is underreported in other parts of the world, but we also know that the prevalence is likely higher in more Western countries. And the lifetime risk for atrial fibrillation is very different for women than men. Over time, the prevalence increases so that women are older at the time of diagnosis of AFib, but are no less likely to develop thromboembolic complications. So important to identify this arrhythmia in our women and male patients and to treat the risk accordingly with regard to anticoagulation. Let's talk briefly about heart failure in women as well. I told you before that heart failure is the number one cause of hospitalization in the United States for women and men, but this data shows us that women are a greater part of the population that is hospitalized for heart failure. As the other diseases I've shown you, the incidence of heart failure rises with age, so that by the 7th decade for women and men, the incidence is the highest, as is the prevalence of heart failure for women and men. So in general, it is a disease of the elderly, if we look at the U.S. population, and these are the patients who are at the greatest risk. This is important data from the Framingham Heart Study, and what it has looked at is the various risk factors for developing heart failure in men versus women. The blue bars are women, the orange are men, and what we see is that diabetes and hypertension are the driving risk factors for the development of heart failure in women, whereas for men, myocardial infarction is really the driving risk factor. So we should all think of our women patients who have hypertension and diabetes as already having heart failure, because they already do. They have stage A heart failure. With regard to lifestyle factors that can prevent heart failure, this is data from the Physicians' Health Study, reminding you that this is 40-year data. These are all male physicians. And what was analyzed was several risk factors for what could prevent heart failure. And those include low BMI, not smoking, exercising frequently, moderate alcohol intake, breakfast cereal consumption, and then fruits and vegetable consumption. And look what happens for men who adhere to each of those lifestyle each of those lifestyle factors, including they exercise regularly, have a low BMI, eat fruits and vegetables, drink moderately, and consume breakfast cereal. For those who have greater than or equal to 4, the adjusted lifetime risk of developing heart failure for men dramatically lower, and this is true even accounting for antecedent myocardial infarction and hypertension. So lifestyle very much matters when we think about the onset of heart failure. Do we have similar data in women? Not exactly, but what we know about development of heart failure in women was driven, this is one study that shows us what are the risk factors for developing heart failure if a woman has coronary disease. And several risk factors were analyzed, and that you can see that they're listed here. And what these investigators found out, and this is the HERS study, they found out that diabetes in women, no matter what other risk factor she had, was a driving risk factor for the development of heart failure. So again, this is more data telling us that women with diabetes are at very high risk for developing heart failure. This is the same data from the HERS study that also shows us that a woman who has diabetes and renal insufficiency is 13% more likely to develop heart failure than a woman with coronary disease who has neither of those risk factors. I'm going to end with some information that we collected now many years ago about how we determine these sex-specific results. And what I and some other investigators did was to look through both the internal medicine literature as well as the cardiovascular journals to see how frequently trials reported outcomes based on sex. And what this slide shows us is that 37% of the internal medicine journals reported sex-specific outcomes. So one could actually analyze, were there differences in outcome between women and men? So 37% of internal medicine journals, but only 23% of our cardiovascular journals, which the three we analyzed at the time were the American Journal of Cardiology, the Journal of the American College of Cardiology, and Circulation. So without having journals and editors ask for sex-specific outcomes, we are unable to analyze data like this. So I'm going to say in summary that sex clearly matters when we're thinking about risk factors and cardiovascular disease. And in order for us to explore any of these sex-based differences in cardiovascular disease, we have to have patients in trials and registries in adequate numbers that we can actually analyze the results. And they also have to be reported in journals. And so we need editors and reviewers who will demand this type of reporting from the investigators who report their results. And once we have this in place, these editorial guidelines in place, we'll be in a better place to help our women and our men patients. Thank you.
Thank you for the excellent review. We have time for a few questions. Please introduce yourself and
Thank you, Dr. Omari, for your nice presentation. I'm Nawaf Oakley, cardiology fellow in Heart Hospital, Doha. I have a few questions, but the first one, since the hypertension is the leading cause of heart failure in women, is the target of treatment same in women and men, or should be more strict with women?
I missed what what should be more strict in men and women?
The target of treatment.
Cardiac. Target treatment for hypertension?
Yes.
There's no difference in the recommendation for the target for hypertension between women and men. However, we do know that women are older at the diagnosis of hypertension. There is a reluctance sometimes to treat older people, but there is no difference in the recommendation with regard to target. There is a reluctance because of the belief that older patients may have more frailty and may have more tendency to fall, but we know that the risk of hypertension is significantly higher. So the guideline writers have not made a difference between women and men with regard to the target.
And the second question, what's the safety of pregnancy after coronary dissection in women?
Pregnancy? What?
After coronary dissection.
What is the risk of subsequent pregnancy after coronary dissection?
Yes.
Coronary dissection is more common in women than men, from what we know. We know little about this condition, though. It's the information that we have is primarily derived from registries. In the United States, the largest registry is currently a self-reported registry that the Mayo Clinic is running. So predominantly women, a lot of women have had dissection after pregnancy, but not all. We don't know enough about dissection to counsel women against another pregnancy. That's a very individualized decision. But there is not robust data that a subsequent pregnancy causes higher risk. So in general, it's really up to an individual woman.
Okay, thank you.
Yes.
I'm Dr. Mishra from Al-Ahli Hospital. As far as the prevention and risk for developing cardiovascular disease is concerned, obesity plays a major role. Can you throw some light on obesity paradox?
The obesity paradox in heart failure?
As far as heart failure is concerned, as far as hypertension, mortality, MI is concerned.
Well, there's not an obesity paradox in cardiovascular disease. So because obesity is an independent risk factor for the development of cardiovascular disease, where the obesity paradox comes into play is with regard to heart failure. So for reasons that we are still not well known, obese patients tend to do better from a survival standpoint. And I don't think we have as yet a solid answer on that.
Thank you.
I'm Dr. Hafiz, the cardiology fellow in Heart Hospital, Doha. My question was regarding what we saw in the data here is that there's big differences in cardiovascular outcomes. So won't we expect, the recommendations in the guidelines to be gender specific?
You mean for all various
Like
recommendations?
Exactly, as if we have the update recently on the hypertension.
Yeah.
We don't see any specific recommendation for different genders, male, female. So do we expect it?
We don't expect it as yet because although we're trying to, in each area of cardiovascular disease and other diseases, to get outcome data to look at what we know about the differences between men and women, we don't know enough yet to target things differently. Similarly, another question would be, we know that African Americans are at much higher risk with regard to hypertension just because of the prevalence, but the targets remain the same. So I think we have to continue to do more research before we would ever have the insight to be able to change targets if it were appropriate.
Thank you.
Do we have data suggesting that women are treated differently than men in heart failure, for example, or in cardiovascular disease in general?
Yeah, we do have data on that. We also, firstly, we have data that with regard to, for example, first myocardial infarction, women arrive at the hospital later than men. On the average, if we look at the early door-to-balloon time data and what was the NERMI registry in the United States, it's about 2 hours later than men. And at the time of a first myocardial infarction, women are more commonly widowed and live alone. So some of those factors kind of play into that later arrival. But we have growing data that women are not offered the same therapies as well, including primary PCI for STEMI. So that women are offered atrial fibrillation ablation much less commonly. So there are, and one of the pieces we don't know is, do we as clinicians offer these therapies less, or are they offered and do they decline them? So that's an area of a lot of research interest.
Thank you very much. I think we'll move to the next speaker. And unfortunately, Dr. Raja Deshti could not come. So we changed the order of the speakers this time to give an alternate flavor of ACC and GHA. So our next speaker is my friend, Dr. Mohammed Makheni, Senior Consultant, International Cardiologist, the National Heart Center and the Royal Hospital in Muscat, Oman. And he's going to talk to us about pregnancy and valvular disease. Mohammed.
Assalamu alaikum. Good morning, everybody. Thank you, Mr. Chairman. It's really a great pleasure to be here, and I would thank the organizing and the scientific committee for inviting me. It's really a great pleasure and a great honor. Pregnancy and valvular disease. Dr. Welsh actually showed you that women live longer, more than men. And I'll show you that women, they die early. So pregnancy and valvular disease. Pregnancy imposes a stress on the cardiovascular system in a pregnant lady, and it will unmask symptoms which were hidden before pregnancy. So during pregnancy, the hemodynamics, you can see that the plasma volume, the cardiac output, the heart rate, they increase, and the stroke volume as well. And as you can see that the cardiac output increases up to the first trimester and then plateaus. However, the plasma volume and the heart rate increases. And the right hand of the slide, you see that during the contractions, the uterine contractions, that the cardiac output doubles. So a lady who was holding, or you are holding her during pregnancy without any intervention, she might decompensate during delivery, and you might anticipate a C-section for her. Cardiac disease in pregnancy imposes a lot of morbidity and even mortality. These are data from the Ministry of Health of Oman. Over 5 years, we had 79 maternal deaths. 5 out of them were cardiac, and 2 out of the cardiac cases were valvular. So the care for a pregnant lady really comes before she conceives. So there are risk stratification models in the literature which you can look for and apply it in your high-risk pregnancy clinic. There is a CARPREG risk model, which is the cardiac disease in pregnancy. There is a Zahara, and there is a modified WHO risk stratification. For example, the CARPREG, according to the CARPREG study, according to the number of risk factors, and this slide will summarize it better for you. Let's say if you have a lady with inflow or outflow obstruction, let's say severe aortic stenosis, this will make the risk of cardiovascular decompensation during pregnancy about 27%. If she has another factor like LV dysfunction, then really this will triple. So there is a 75% chance that this lady will decompensate. Yes, this CARPREG model had been criticized because it overestimates the risk, but really it has been validated in many studies. So you can choose any model and utilize it and apply it to your patients when you are running a high-risk pregnancy clinic. Mitral stenosis. Mitral stenosis is the Cinderella of the valvular disease. We still see patients of mitral stenosis, and it's actually the commonest valvulopathy we come across in our clinical practice, especially for pregnant ladies, especially in this part of the world. Although it is less aggressive than other countries because of modernization, but still we see them. The mitral valve area is 4 to 6 centimeters square. When it comes to less than 1.5, then the chance of decompensation is very high. The risk of atrial fibrillation, although it is low, but increases the thromboembolic risk more than non-pregnant lady when they develop the atrial fibrillation. Overall mortality, remember this figure, up to 3% overall mortality for a significant mitral stenosis in a lady who's coming pregnant to you. So you keep it in your mind. So you anticipate intervention before she conceives. This is another data from Uriel Kiam. As you can see, 35% maternal complications for ladies with significant mitral stenosis, 31 acute pulmonary edema, 11 arrhythmias, 10% embolic events, and 3% deaths. Fetal prognosis is also is not better. The prematurity, intrauterine growth retardation, low birth weight, stillbirths are very high in patients with mitral stenosis, even if you don't intervene and you try with medical therapy during pregnancy till they deliver. So you keep in mind, these are the fetal complications of patients with significant mitral stenosis. Again, from another series, acute heart failure can occur during delivery or immediately after when there is a volume redistribution. They can go into pulmonary edema, so you keep them in high dependency. Prematurity, as I said, 30%, intrauterine growth retardation is 20%, stillbirth is 1 to 3%, and risk is higher, those with NIHA class 3 and class 4. So what to do? Counseling against pregnancy is really difficult. She's coming asking you, I want to conceive. You tell her, don't conceive. She'll tell you, hell with you. I'll look for another cardiologist and ask for his consultation. So if you diagnose a case, better to intervene before she gets pregnant, especially with a patient having significant mitral stenosis. Even if she's asymptomatic, you know that there's 30% chance that she will decompensate. So you anticipate the intervention before. Or if you catch her while she's pregnant, then we try to delay any intervention till about 20th week because you want to avoid radiation during the organogenesis. So what are the management options? Medical therapy, you try during the first trimester to pull her to the second trimester with diuretics, beta blocker to space the diastole, and rest. Try to avoid surgery. Try to avoid surgery, because the moment you put a pregnant lady on the cardiopulmonary bypass, there is a 25% chance that she will lose the baby. Because the moment you put her on a cardiopulmonary bypass, you are compromising the placental bed circulation. And there is a very good chance that she will lose the baby. So try to avoid surgery as much as you can. So what's the best option? The best option is percutaneous balloon valvoplasty. And the best among them is the NV balloon, which is the best. Double balloon technique had been advocated, but the double balloon technique invokes longer time, radiation is more complicated. Why it is used double balloon? Because it's cheaper. In certain countries, they cannot afford the NV balloon, so use the double balloon technique. But NV balloon is much better. Then the question which comes to you by the couple or by the mother, I mean, you are taking me to the cath lab for intervention. Now the risk of radiation. What's the risk of radiation? The risk of radiation has two parts. One of them is the timing, the time when you deliver the radiation, and the other one is the dose. The timing, if the first 2 weeks of pregnancy, during the implantation, radiation, either you will have no baby or you'll have a normal baby. After that, the organogenesis, where is the risk of the radiation risk to the baby. Try to avoid it. The permissible dose is around 50 milligrams. As if you concentrate from this slide, if you see the last row, PCI 3 milligrams, and this is for the fetal, and for the maternal is 15. This is during PCI. PCI, we know that you are taking cine loops. You are taking cine, and cine is about 10 times the amount of radiation of fluoroscopy. So imagine that during the balloon valvoplasty it will be less. Second thing, when we are doing as interventional cardiologists, the lowest frame rate, those who are doing intervention will understand it. The lowest frame rate, we can go up to 7.5 frames per second, because you need really high definition for the coronaries. When you are doing a balloon valvoplasty, you can go as low as 2 frames per second. So you can lower the amount of radiation. Put the abdominal shield. Avoid any angulated. The steeper the angulated the views, the more scattered radiation, the more radiation exposure. Use the transesophageal echo to help you during the transeptal and during the balloon positioning. So using these measures, you can reduce the amount of radiation exposure to the mother and to the fetus dramatically. So it's not really a big risk, especially if you are doing it in the second trimester. Surgery, as you can see from the slide, over many years the risk hasn't changed, even with modernized and all the techniques and the protection, the heart protection during the open heart surgery. You can see that 20% risk of fetal death. So it's really the number is scary. So think twice before when you are consulting with a surgeon to intervene surgically on such a patient. Aortic stenosis. Aortic stenosis is not as common actually as mitral. Usually, the ladies in childbearing age, they have a bicuspid aortic valve. Usually a bicuspid aortic valve. We see rheumatic, but usually when you have a rheumatic aortic stenosis, almost always there is a mitral involvement with rheumatic fever. So this will increase the risk more. And ladies with class 1 and class 2, they can tolerate the pregnancy, but you have to accept, keep it in mind, even if they are class 1 or class 2, there's about 10% chance that they might decompensate. The problem, the treatment options are very limited, and I'll show you. As I said, in mild or moderate, they can go through their pregnancy without any problem. And those asymptomatic, good exercise tolerance and good BP response also can tolerate pregnancy. And some experts, they advocate to do an exercise test for the patient to see their functional capacity before they get pregnant. Heart failure, as I said, 10%, and arrhythmias about 3 to 25%. Mortality is very rare in aortic stenosis. It's not as mitral. And you can conceive it because, the proximal part in mitral stenosis is the left atrium. There is not much of muscle to overcome that obstruction. However, in aortic stenosis, the proximal part is the LV. It can generate a pressure of 300 to overcome that obstruction. Preterm and IUGR, intrauterine growth retardation, again, is about 25%. Treatment options. All symptomatic patients should be counseled against pregnancy. But if they disagree, then you have to intervene. And unfortunately, the treatment options are very limited. Balloon valvuloplasty, the recommendation is that the valve should not be calcified. And this is very rare to have a bicuspid aortic valve which is stenotic that it is not calcified. Most of the time it's calcified. And there should be no regurgitation. So this treatment option is, you can offer it to a lady when she is already pregnant and you don't want to subject her for the valve replacement. So as I said, so balloon valvuloplasty is not a treatment option except in a very limited number of patients. Delivery, when you have severe aortic stenosis and patient managed through, better to deliver them by C-section. Although they say delivery should be an obstetrician decision, but here the cardiologist will come in the scene and say better to go because she might decompensate during delivery or immediately after delivery. If the patient having moderate AS, you can recommend vaginal delivery, so it's not a problem. Pulmonary stenosis is always congenital, and usually it's well tolerated even if it is severe. And rarely balloon valvuloplasty will be needed, and even if it is needed, it's far simple than the balloon mitral. So the radiation exposure is very minimal and can be done safely. Mitral and aortic regurg. Just remember, if you see the the second slide or third slide, that the pulmonary vascular resistance drops by 30% and the systemic vascular resistance goes by 20%. So regurgitant lesions are usually well tolerated compared to stenotic lesions in pregnancy. So rarely you need to intervene on the mitral. Regurgitation which is severe or aortic regurgitation which is severe. But if you see the case, it's really here a tough call because you don't have any catheter-based intervention in regurgitant lesions, severe regurgitant lesion in a young patient. You don't want to clip a mitral valve for a lady to get pregnant. If the lady has severe mitral regurgitation, if the valve is repairable, that's a good scenario. But then the valve is severely deformed and she has to go. You will pull her from one problem to another problem where there is a prosthetic valve, and she has to get pregnant with a prosthesis, which is another problem also. So really, the decision he's really a tough call for you as a cardiologist. Fluid overload should be managed medically in patients with severe regurgitant lesions, and decision for intervention and timing should be between the obstetrician and the cardiologist and the cardiac surgeon. So you need really a multidisciplinary approach in such cases. But as I said, regurgitant lesion is really a tough call sometimes, especially if the patient is willing to conceive and she has severe aortic or mitral. On the other hand, because you don't want the patient asymptomatic, why do you want to operate early? That's the LV dimensions are normal, ejection fraction is more than 60%, and she is willing to conceive and she's class 1. Will you subject her for surgery or not? I don't know. It's not clear actually. Valvular atrial fibrillation, when related with MS, high thromboembolic. And this has been really from Framingham study. They found the patients with mitral stenosis, atrial fibrillation, they have 18-fold increase in thromboembolic phenomena. For this reason, and this is very old data, for this reason, when they started to anticoagulation for non-valvular, it was felt unethical to randomize valvular cases like mitral stenosis to anticoagulation and non-anticoagulation. And the thromboembolic or hypercoagulable status of pregnancy increases the risk even more. So the moment you diagnose it, immediately you anticoagulate them because the risk is really, really high. Prosthetic valves. This is another really a difficult situation, especially in the high-risk pregnancy clinic. Valve implantation selection is problematic, and you have to involve the couple or involve the lady in the decision. And the decision is really very active. The role is very active. One hand, you have a prosthesis, metallic prosthesis, which can be durable for many years, but there is a risk of valve thrombosis. On the other hand, you have a bioprosthesis, which you don't need anticoagulation, but the lady, she has to accept that there is a 50% chance in the next 10 years that she will undergo a redo valve surgery. Some women, they say, it's okay, I will go for a bioprosthesis till I complete my family, and if the valve degenerates, then you can put a metallic valve. And as I said, it's the choice of the lady. There is no clear data that pregnancy accelerates the degeneration of the bioprosthesis. Yes, it's a hyperdynamic circulation, the wear and tear, etc., but we don't have any strong data to suggest that multiple pregnancies accelerate the degeneration of bioprosthesis. Redo mortality is 0 to 5%, and this has to be really clear for the lady when she decides for the bioprosthesis. This slide shows you the types of prosthesis in the market, and with variable thrombogenicity. And we don't see the caged ball except in cases of India and Egypt sometimes. It's still with the caged ball, which is the Star Edward in the far right-hand side. Mainly now we see the bi-leaflet valve and single leaflet tilting disc. And the second is the bioprosthetic valve. The TAVI is no more except in very selected cases where you catch the case pregnant and severe aortic stenosis, severe LV dysfunction, and you do TAVI. And in Oman we did one case actually. Our colleagues in the university, they did one case on a pregnant lady. They did TAVI. And she sailed through her pregnancy nicely, and she delivered. But as I said, the TAVI is not an option actually in pregnant ladies. The incidence of the prosthetic valve thrombosis, it's 0.2 to 1.8% per patient per year for those who are well anticoagulated and well monitored. And major determinants, adequacy of anticoagulation, valve type and position. It can go up to 20% if you have a tricuspid prosthesis with atrial fibrillation and RV dysfunction. So it's really bad news. And valve thrombosis is a bad news also. I mean, the risk of mortality is very high. In pregnancy, it's even more because of the hypercoagulable state of pregnancy. It's up to 3.9%, although the recent series shows about it can go down up to 2.4%, but far less better than heparin. Heparin about 10% risk of valve thrombosis. And never give subcutaneous heparin. It's all IV heparin. Subcutaneous heparin, sub-Q, the unfractionated heparin has a very erratic blood levels, so you cannot maintain a stable pharmacokinetics. Low molecular heparin carries a risk, even when you monitor the anti-10A levels. And there was, at the beginning of 2000 or 2001, there was a warning from the manufacturer himself that they cannot guarantee the safety of the low molecular heparin in prosthetic valves. So what's the best? The best is warfarin throughout pregnancy. Superiority of UFH or low molecular heparin in the first trimester is unproven, and there is a higher efficacy, which is questionable, of low molecular heparin because low molecular heparin has more stable pharmacokinetics compared to unfractionated heparin. Risk of hemorrhage, miscarriages, embryopathy is there when you give the lady the warfarin. She said, okay, I'm taking the warfarin, what are the risks? There is a risk of embryopathy, skeletal deformity, etc. And the risk is more, it has been shown in the literature, the risk is more if the dose is more than 5 and less when it is less than 5. So a lady with 5 milligrams, I mean, you can take her throughout pregnancy with this dose. But if she needs more, that's the time when you tell her the risk of embryopathy is around 8%. And most of the ladies, they will tell you, I want a normal baby. I don't want my kid to suffer. Allah yarham ummahatna yani. she will risk her life just to have a healthy baby. So, but it has to be clear to her, to the patient, that this is the risk, and she can choose whether to go with warfarin or to go with the low molecular heparin. This is from Al-Qiyam. They found actually those patients, this is according to the guidelines, even if you stick to guidelines, they say that you have to monitor the anti-10A from 0.8 to 1.2. Fair enough. But many studies have shown that when the pre-second dose level was checked, it was subtherapeutic. So those patients, during a few hours in the day, their anticoagulation effect was subnormal, and they are at risk of valve thrombosis. So what Yuri Al-Qiyam, he's one of the experts in this field actually, he proposes this, which you need to monitor the peak and the trough. And they segregated the patients into high risk and low risk valve. High risk valve is the old generation valve, and low risk are the new generation. So you monitor the trough. The trough should be more than 0.6 when you have a low risk, and should be more than 0.7 when it is a high risk. And you have to keep the peak less than 1.5. This is very attractive, very appealing, but needs more studies to prove its efficacy, though it's much better. It's the best of the two evils. If the lady is needing more than 5 milligrams of warfarin, then you might choose this protocol with the low molecular heparin. There are normograms in the literature, how much you adjust the dose according to these normograms by the manufacturer. But I found it actually from 20 to 40% increase or decrease the dose according to anti-10A level. So to conclude, ladies and gentlemen, pregnancy and valvular disease is a management challenge for the obstetrician and for the cardiologist. It needs always multidisciplinary approach. Patient involvement in the management decisions is very crucial. And thank you very much for your attention.
Thank you, Dr. Mohammed. We have time for a couple of questions. Yes, please.
Fadi Khazal, Cardiology Fellow, HMC. Thank you for your great talk. I have one question. What's your recommendation regarding female patient with severe aortic stenosis, normal ejection fraction, and she wants to get pregnant? Thank you.
And she's asymptomatic?
Asymptomatic.
Asymptomatic. Some experts, they say just put her on a treadmill, and if she does well on a treadmill, she can go, but she has to accept there is a risk of that she might decompensate, 10% risk of decompensation. But people have done this. Because the problem with aortic stenosis, as I said, there is not much of management option. Balloon valvuloplasty is not an option except as a bailout or a bridge for something. So some experts, they will say just they let her sail through pregnancy, but she needs very close monitoring. Okay. But she's asymptomatic, class 1, yes. It's okay, you can do.
Thank you.
Also, you look at the gradient. What was the mean gradient? If the mean gradient is 50, more than 50, then it's a tough call also.
Thank you.
So I have a question also. In our lifetimes, the treatment of women who are pregnant or wish to get pregnant with mechanical valves has really changed dramatically. From hospitalizing the woman early on and with unfractionated heparin to now warfarin during the pregnancy. What is your experience? There are a lot of centers in the United States that are using the pre-pregnancy warfarin dosing to helping a woman make a decision about how she's going to go forward, either with warfarin or low molecular weight heparin.
So
what's your experience with analyzing those factors pre-pregnancy?
Well, it's a very good idea, but there was a study in 2012 actually published in JACC, taking patients before they get pregnant and see what's the average dose of warfarin they need, and if it is less than 5 or less, they can go through pregnancy. We don't have that system, but it looks very, very, very encouraging to see. And we don't have a pre-pregnancy clinic or pre-pregnancy counseling, which is really a must, especially for the ladies when you see them with in your cardiology. Usually they are followed up in cardiology clinic, And when you are called in the high-risk pregnancy clinic, they're already pregnant. So we need that kind of what's called information, basic information, if you are willing to get pregnant. Usually, personally, I tell them, just invite me if you are getting married. This is what I tell them. So I say, why? I tell them this is for this reason. But we don't have some sort of a system where really you do pre-pregnancy counseling clinic. So we see them already pregnant with our obstetrics colleagues. But it's a very, very good idea. The problem with warfarin, it's very, very erratic, the steady states of warfarin. So I don't know whether in pregnancy, those patients, even with 5 milligrams of warfarin, they had been shown even they can get even embryopathy. So that's a good idea. Any questions? More questions?
Last question, okay.
In a patient who was, Abdurrahman Arabi, director of the Cath Lab Heart Hospital. In a patient who was stable on warfarin prior to get pregnant and she has prosthetic valve, how often you monitor INR? Like if she is stable, like she gets INR every 1 month and she is stable?
Yeah, every 2 weeks. Every 2 weeks in the first.
Every 2 weeks. Okay.
Every 2 weeks. This is not my recommendation, it's the expert recommendation. I'm miskeen. I cannot make a recommendation myself.
Okay, thank you, Dr. Mohammed.
Okay.
Thank you very much.
Our next speaker is Dr. Frederick Massoudi. Dr. Massoudi is a trustee of the American College of Cardiology, and he is professor of medicine at the University of Colorado. And he's also the chief science officer of the National Cardiovascular Data Registry at the ACC. And his talk today is on the National Cardiovascular Data Registry programs, a bridge between evidence and cardiovascular practice. Dr. Massoudi.
Thank you, Dr. Walsh, and thank you to the organizers for inviting me here. This is now my second trip to the Gulf Heart Association. I was here in 2010 in Doha at this meeting as well, and I can't tell you how much I appreciate the opportunity to be here and for the warm welcome that you have all extended to me. I'll be talking today about the American College of Cardiology's National Cardiovascular Data Registry, or NCDR, programs. Let's see here. Okay, need a little. Using the. Not having green on, yeah. Decided it doesn't want to advance. Just a moment, I apologize. There we go. Thank you. These are my disclosures. For those of you who have not seen this slide, when I think of science in medicine, I think of the translation of science from the very basic of the research that is done in mice and with genetics into clinical trials. And from those clinical trials, there's the development of guidelines. And those treatment guidelines help us determine what we should be doing when we deliver care in practice. Those guidelines have been translated by the ACC and the American Heart Association into performance measures that are used to monitor the progress of adapting guidelines in care, and the adoption of those guidelines into care presumably improves outcomes, and the understanding of the care that is delivered helps inform future science. What was learned early in the process of developing practice guidelines is that guidelines themselves do very little to change the care that is delivered. Guidelines, when they're published, clinicians will look at them and they sit on shelves. And so there is this well-known barrier between the translation of all the science that is developed, all of the basic science, all of the clinical trials, and even the development of guidelines is worth very, very little unless we understand how that is translated into care. And this is where the NCDR comes in. The mission of the NCDR programs is to improve the quality of cardiovascular care by providing information, knowledge, and tools, implementing quality initiatives, and supporting research that improves patient care and outcomes. And I'm going to provide you with some examples of how this is the case. The NCDR was started 20 years ago with the CAF-PCI registry, which by its name, as you would imagine, is a registry collecting data on patients who are undergoing cardiac catheterization or percutaneous coronary intervention. Since that time, the NCDR has grown into 10 programs, both in the inpatient and outpatient setting, focusing on cardiovascular procedures and high-impact cardiovascular conditions or ambulatory cardiovascular care. The NCDR programs have collected data on millions of patients. The NCDR has touched the lives of more than 75 million patients in the United States with cardiovascular disease, ranging from those in the ambulatory setting with our Pinnacle or Diabetes Collaborative Registry, or patients who are undergoing procedures, like those undergoing percutaneous intervention, those undergoing ICD implantation, those who have heart attack in the ACTION registry, patients with congenital heart disease, patients undergoing percutaneous valve therapy, left atrial appendage occlusion devices, or atrial fibrillation ablation. It's important to recognize that registries are not just comprised of data. The data is a tool. The data is not what the registry is at the end of the day. And furthermore, our registries are not cohort studies, time-limited programs where we're collecting data on patients for a year or 2 years. The registries are ongoing programs. As I said, CAF-PCI has now been collecting data on patients for more than 20 years. And we collect clinical data using standardized data elements and definitions into an ongoing database. We often use external sources of data, such as billing data from our Centers for Medicare and Medicaid Services, to provide us longitudinal views of what occurs with patients. And those data are used for a variety of important objectives, which include quality assessment, quality improvement, and clinical research, with the objective of playing a meaningful role in clinical practice and, in the case of the United States, healthcare reform. One of the important characteristics of our registry programs is the data quality, and we have a rigorous data quality program to ensure that, to the extent that it is possible, the data that are collected are accurate and reliable. And this is a fundamental component of the NCDR programs, because we know that the data that come out of the registry programs is only as good, the information that comes out of the registry programs is only as good as the data that comes in. Now I'd like to focus on the components of the NCDR mission, which I read to you earlier. One of the important components, the principal components of the NCDR, is to provide information, knowledge, and tools to practitioners to improve the quality of care that they deliver to patients with cardiovascular disease. All of the participants in the NCDR programs receive benchmark reports that allow them to see their performance with respect to processes of care, such as the delivery of particular evidence-based medications or outcomes of care, in reports that will instruct them how they are performing relative to other U.S. centers that participate in the programs. You can see in this particular diagram here, an arrow shows the hospital where they perform relative to other programs that are participating in the registries. The data are also flexible. The NCDR now has dashboards that allow physicians and hospitals and healthcare systems to analyze their data in a variety of ways in the manner that they would wish, to compare themselves with various other benchmarks, like hospitals of the same size or physicians in the same sort of practice. One of the other benefits of the NCDR is the ability to identify gaps in care for novel metrics that have not yet been developed. These are data from a study that was performed by one of my colleagues, Dan Matlock, on the use of single or dual lead defibrillators in patients getting primary prevention ICDs who did not have an indication for pacing. So these are patients with left ventricular systolic dysfunction, getting a primary prevention ICD, who have no evidence of conduction abnormality or other condition that would suggest that they might need long-term pacing capability, who are people who generally only need a single lead defibrillator. What we found in this study was that the use of single and dual lead defibrillators varied substantially between different hospitals. And so these, if you look at this, each little bar represents one U.S. hospital of the nearly 2,000 hospitals that participate in the NCDR-ICD registry. And what is along the y-axis is the percentage of patients who did not have a pacing indication that got a dual lead ICD. What you can see is that there are a handful of hospitals where none of the patients got a dual lead ICD, which is probably what should have happened in most of these cases. On the other hand, there are a large number of hospitals where every single patient who was getting a primary prevention defibrillator and did not have an indication for long-term pacing got a dual lead ICD, a device that is more expensive and is associated with more complications and probably was not warranted in these cases. And what else is interesting is you see that all those hospitals in between, varying proportions of the extent to which they use dual chamber ICDs. And we took these data and we transformed them into a novel metric that is now fed back to hospitals, namely the proportion of their patients who appear to need only a single lead defibrillator who are getting a dual lead defibrillator. So this is data generating novel metrics to help improve care and make it safer and more efficient. Another value of the NCDR data is that because so many patients in so many hospitals are enrolled into the programs, that we can develop very robust risk models on the patient level that help us assess a patient's risk for particular adverse outcomes. For instance, we have models within the CAF-PCI and the ACTION registries that assess a patient's risk for bleeding during the hospitalization. Obviously, bleeding is one of the feared complications of PCI procedures. And we now have risk models that allow clinicians to evaluate individual patients and assess their risk of bleeding and make decisions to use bleeding avoidance therapies such as a radial percutaneous approach or using closure devices in those patients who are at higher risk for bleeding. So calibrating treatment to risk. There are many other risk models that have been developed with the NCDR data, including TVT, a TAVR risk score that allows one to assess the risk of mortality from a TAVR or surgical procedure that is now available as an app that clinicians can use with their patients at the time of an evaluation, and again help individualize and personalize the care that is delivered to patients by helping them understand what their risks are for adverse complications, all by virtue of the fact that we have this large, robust, clinically detailed database from which to develop these risk models. The NCDR obviously is critical to the support of quality improvement initiatives. One of the national quality improvement initiatives that was supported by the American College of Cardiology and the NCDR database was the door to balloon time, or D2B initiative. It turns out that despite all the knowledge that had been generated about primary PCI and its importance in patients with STEMI, it was remarkable that in the United States, for many years, the proportion of patients who were getting timely PCI for STEMI was in the range of about 60 to 70%. So maybe a quarter or a third of patients were not receiving primary PCI in a timely manner, despite the fact that there were numerous clinical trials, despite the fact that there were very strong guideline recommendations, again illustrating the idea that guideline development alone and the clinical trials that support them are not adequate to ensure that we're delivering the right care to the right patient at the right time. The D2B initiative, which was started by Harlan Krumholtz, one of my colleagues, and again supported by the college and supported by NCDR, was specifically an initiative to encourage hospitals to employ known structures and processes of care that were known to improve door-to-balloon times. For instance, having a single pager to identify who should be called to activate the cath lab. Having crews within a certain distance of the hospital and making sure that there was a timely both assessment and notification at the cath lab. What we find now in our hospital and so many hospitals across the United States is that patients not getting PCI within 90 minutes of presentation with STEMI is now what we would almost call a never event. In our lab, I know we went more than 450 days without a single patient failing to get treatment in a timely manner. So this has transformed from a situation where maybe a quarter or a third of patients were not getting timely PCI to a situation where virtually all patients are getting timely PCI. It's a huge and dramatic change in the care that's delivered for STEMI nationwide. And I've already pointed out the feedback and benchmarks that we receive on a local level. As the clinical chair of our quality committee in the cardiovascular service line at the University of Colorado, I spend time with our staff reviewing our NCDR reports, identifying the gaps in care that we deliver, and determining the ways that we individually will be improving care at the University of Colorado to ensure that our patients get the best care that they can. Finally, the NCDR has supported cutting-edge outcomes research to help advance our understanding of care that is delivered, care and outcomes in the real world. We now have published more than 400, this is a somewhat old slide, we've published now over 400 peer-reviewed articles in journals such as JACC, JAMA, the Journal of the American Medical Association, and the New England Journal of Medicine, among many others, that have helped us advance the cause of quality of care, safety, and the efficiency of cardiovascular care. And we have performed research in the NCDR that addresses all the Institute of Medicine domains of quality, including the effectiveness, the safety, the efficiency, the timeliness, the equitability, and patient-centeredness of the care that we deliver every day. This is one of many examples of publications that have emanated from the NCDR, a study that we performed in patients in the ICD registry, assessing the observational comparative effectiveness of cardiac resynchronization therapy, or CRT, compared with ICD therapy in patients who had indications for CRT therapy. And our findings were quite similar to those that are published in the clinical trials in terms of the patients who derive the greatest benefit, those patients with left bundle branch block and very wide QRS complexes, helping us support what is known in the clinical trials and understanding that in the real world, the clinical trials appear to translate very well into practice. There have been many evolving roles of NCDR as well. NCDR has helped support not only just quality measurement, but also the maintenance of certification or other requirements for physicians with respect to their license, and supporting quality improvement activities that allow physicians to obtain credit for these quality improvement activities. We've also worked with payers, most importantly the Center for Medicare and Medicaid Services, which supports the Medicare or old age insurance program in the United States, as well as the U.S. Food and Drug Administration in developing programs. And in fact, two of our programs, the STS-ACC TVT registry and the left atrial appendage occlusion program, have both been developed in conjunction and in cooperation with the FDA and with CMS, both for the purposes of performing post-market surveillance of catheter-based valve therapy and left atrial appendage occlusion therapy, and also with the Centers for Medicare and Medicaid Services to satisfy what are called coverage with evidence decisions, or those situations where hospitals must participate in a registry program in order to be paid for doing particular procedures, in this case, transcatheter valves or left atrial appendage occlusion device procedures. And in fact, the STS-ACC TVT registry has supported expanded indications for particular technologies. In this case, valve-in-valve valve-in-valve catheter-based procedures, both in the mitral and aortic position, the data that came out of the TVT registry helped FDA make decisions about the appropriateness or the appropriateness for approval of these transcatheter valves for valve-in-valve delivery. In fact, these were approved for further use in large part based on the data that emanated from the TVT registry. We have also ventured into the performance of randomized controlled trials using the registries. The SAFE PCI trial was the first US-based multi-center prospective RCT that was comparing radial and femoral approaches. It was a study that was performed solely in women, apropos to Dr. Walsh's excellent first talk. And it was the first registry-based trial in the United States with patient-level randomization. And there are a number of challenges to performing randomized trials within registries, but we know that the registries can also provide a platform for collecting very detailed, consistent clinical data to support many activities, not just quality improvement, not just national programs, but also potentially randomized controlled trials. The NCDR also is very important to us because it helps us advocate at the governmental level in support of patients. And the NCDR has appropriately, I think, given the American College of Cardiology and its partners a great deal of credibility because it allows people who are responsible for developing laws and developing policies to understand our commitment to our patients and to the quality of care that we deliver. They know that this requires a substantial investment. They know that the data are good and that the insights that are generated by the data are important to understand. You can see by virtue of our relationships with CMS and the FDA, the registry programs provide us with a great deal of credibility to allow us to support laws and regulations in the interest of our patients. And we have found that the data are very, very important to supporting our mission to advocate for patients. Again, I hope that I provide you with an overview of how the NCDR supports its important mission of providing information, knowledge, and tools, implementing quality initiatives, and supporting research that improves patient care and outcomes, and helps us break down this barrier between the guidelines and practice that we have seen so many times in medicine. In the United States, we say that quality healthcare is a team sport. And this is the case in my work at my hospital, that quality is a team sport. And what that means is that it's not just about the physicians. It's about the nurses. It's about the quality personnel. It's about everyone who interacts with the patient. We act as a team. And quality care is also an international team sport. We have a number of international participants in the NCDR, and I'm happy to know that Hamad is now joining us in the NCDR family in its goals to collect data, to understand the care that it's delivered, and to do the right thing for the right patient at the right time with cardiovascular disease. And with that, I will say thank you so very much for having me. Again, it is my pleasure to be here, and I will take questions. Thank you.
Thank you, Fred. Questions for Dr. Massoudi?
Thank you for the wonderful presentation. Abdurrahman Harag, Director of the Cath Lab, Qatar Heart Hospital. I agree about registry will help to close the gap between what we know and what we do. And during the conference, there was a lot of talks and emphasis on importance of training fellows about research. I wonder if NCDR or ACC did anything to train fellows for quality improvement projects, which will help to close this gap.
Yeah, it's a great question. And there's nothing more important than training the next generation of physicians and other medical practitioners in the importance of quality improvement. And the college has a very robust fellows in training group that is incredibly interactive and is involved in many aspects of the college activities and in NCDR activities. And in fact, We have fellow in training spots on every one of our research and publications committees within NCDR. We have involved fellows in training in a variety of different components of NCDR work. I can say, speaking locally, we use NCDR as a tool to help facilitate quality improvement activities by our fellows. In fact, I'm working on instituting the Pinnacle Registry, the ambulatory registry program, in our fellowship clinic. And so our fellows are now using Pinnacle, the ambulatory registry, to assess the care they're delivering and have the capacity to compare that to the care that's delivered in ambulatory cardiology across all the Pinnacle sites. And so NCDR is a very important tool to help foster the interest and allow fellows to understand the importance of quality improvement, because again, it's a very important component of training now in the United States, is understanding quality. In fact, it's a requirement of the American College of Graduate Medical Education that fellows be involved in quality improvement activities. And we're fortunate in cardiology that we have these tools to be able to use for the purposes of quality improvement.
Thank you.
Yep.
Fred, can you I know that you mentioned that Hamad is going to be joining the Pinnacle Registry. Can you fill us in on the extent of Pinnacle around the globe as of right now and the other registries?
Sure. So we have many international sites for the various programs, including CAF PCI is used in a number of sites, including in the UAE and Saudi Arabia and others. Pinnacle is being used in centers in Brazil, in India, and is being adapted here as well. So we have a variety of different sites that are interested in various different programs. As you can imagine, there's been some interest in impact as well, being congenital heart disease procedures. And so we have a growing family of sites that have become very interested in using NCDR as a means for understanding the care they deliver around the world.
If there are no other questions, thanks, Dr. Masudi, and thanks to all of you for attending our joint session, and we hope you have a good rest of the day with the other sessions. Thank you.
Actually, there is no break, so we can continue actually for the next session, if you don't mind. We'll go the next session, ESC, ECC, JHA. We can proceed so we can finish earlier for lunch.